some unreleased ones. He's absolutely brilliant. Groovy, techno, psychedelic influences. That's coming up in the second hour. In the first hour, I put together a mix of the latest and greatest tracks from progressive house all the way through psychedelic. Let's get the mix started with a fantastic new release from Diablo, Electricity. And you may remember that Diablo included a on his guest mix for us here on Pharmacy Radio back in July. But at that time, it was an unreleased at the time. Well, it is out now and it's going to pick up on its today. Hello everyone, this is Diablo. I hope you are moving your head. This is Pharmacy Radio with Christopher Lawrence.
Today we're excited to bring you a conversation with Kate Rydell, Assistant Professor of Pharmacy at Butler University and a practicing community pharmacist in Indiana. Kate has a unique role blending academia with hands-on community practice. And in this episode, she shares her journey, her perspective on where pharmacy is headed, and how she's preparing the next generation of pharmacists. Let's dive into the conversation.
My name is Kate Rydell, and I currently have transitioned into a newer role as an assistant professor of pharmacy at Butler University in Indianapolis, Indiana. It's actually my alma mater, so it's pretty cool to be back. And in this role, I get to continue to practice at a local independent pharmacy just north of Indianapolis. It's Cowan Drugs and Parkside Pharmacy. They're two locations in the same town. I've worked there part-time and in full-time roles over the past few years. So I get to continue to do that as part of this role, which, especially being in the academic space and working with future pharmacists, I think it's really nice to be able to pull that clinical real-life experience into those roles. So professionally, that's what I
I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Hypertension is often called the silent killer, but osteoporosis might be considered a silent and deadly disorder. This is the People's Pharmacy with Terry and Joe Graydon.
If an older person breaks a hip, the consequences can be disastrous. They often lose mobility and they may even die.
The focus for osteoporosis is usually on older women, but we should remember that men can also lose bone and become vulnerable.
There are drugs that hurt bone health as well as help build it back. What about supplements or exercise?
Coming up on the People's Pharmacy, the science of strong bone, lifestyle, medication, and movement.
Semaglutide has gotten a lot of attention over the past few. If you don't recognize this generic drug name, you probably do recognize the brand names. Ozempic for type 2 diabetes and Wegovy for weight loss. Both these medications are self-administered injections, but not everyone is enthusiastic about needles. There's also an oral form of semaglutide called Rybelsus. The FDA has approved it for treating type 2 diabetes 6 years ago, and so far it has mostly gone under the radar. A new study published in the New England Journal of Medicine demonstrated that oral semaglutide at 25 milligrams a day helped people without diabetes lose significantly more weight than placebo. The randomized trial included more than 300 volunteers and lasted approximately a year and a half. This could be good news for people who have trouble accessing injectable semaglutide or keeping it cold. People taking semaglutide reported improved quality of life. They were also more likely to report side effects, especially digestive distress.
Aspirin has been available for well over 100 years, but the active ingredient has been used by native healers for thousands of years. In 1991, a research article in the New England Journal of Medicine reported that regular aspirin users were 40 to 50% less likely to die of colon cancer. Now, 34 years later, another research paper in the New England Journal of Medicine reports that people taking aspirin had a significantly lower chance of colorectal cancer recurrence. Swedish scientists recruited patients after they'd had their tumors removed. The researchers were specifically looking for cancers that had a particular hotspot mutation called PIK3CA. The aspirin dose was 160 milligrams, or roughly half a standard strength tablet daily, for 3 years. 626 patients were randomly assigned to receive either aspirin or placebo. 7.7% of people taking aspirin experienced a recurrence of their colorectal cancer, whereas 14.1% of those on placebo had a recurrence. That was about a 50% relative risk reduction. 43% of the participants taking aspirin experienced a non-severe side effect compared to 35% of those on placebo. Serious adverse events occurred in 17% of aspirin takers compared to 12% of placebo recipients. The authors conclude that low-dose aspirin represents an effective, low-cost treatment approach to prevent colorectal cancer recurrence in high-risk, genetically selected patients.
Nutrition experts have praised the Mediterranean diet as a way to reduce cardiovascular risk. It's also been considered as a way to lower the likelihood of developing dementia and a natural approach to calming inflammation. Now, dermatologists have announced the results of a study showing that 4 months on a Mediterranean diet can reduce the severity of psoriasis symptoms. Almost half of the participants following a Mediterranean diet reduced their psoriasis score by 75%, and none of those on the control diet did so. The researchers conclude that this dietary strategy could be helpful along with medical treatment.
A new study of acupuncture for chronic low back pain called Back in Action produced positive results. 800 patients were randomized to receive either standard acupuncture of 8 to 15 treatment sessions, enhanced acupuncture, which included 4 to 6 maintenance sessions beyond the standard, or usual medical care alone. Those in the acupuncture groups had significantly greater reductions in their pain-related disability than those in the usual care group. The authors conclude that, quote, these findings support acupuncture needling as an effective and safe treatment option for older adults with chronic low back pain.
Do cocoflavanols normalize blood pressure? In the Cosmos study, people with systolic blood pressure under 120 were significantly less likely to develop hypertension if they were taking cocoflavanols. Blood pressure started higher did not. People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. According to the CDC, over 10 million Americans over 50 have osteoporosis. That means their bones have become fragile and more vulnerable to fracture.
More than 40 million Americans have low bone mass or osteopenia. What can be done to prevent fractures, disability, and death from weakened bones?
To find out, we're talking with Dr. Kendall Mosley. She is Associate Professor of Clinical Medicine in the Division of Diabetes, Endocrinology, and Metabolism at Johns Hopkins University School of Medicine. She also serves as Medical Director of the Johns Hopkins Metabolic Bone and Osteoporosis Center.
Welcome to the People's Pharmacy, Dr. Kendall Mosley.
Thank you so much for having me today. I'm very excited to chat with you both about a topic that's near and dear to my heart.
Well, it's near and dear to our hearts as well, Dr. Mosley, but I suspect that there's a tremendous amount of confusion when it comes to bones, because we've all seen skeletons, we've all had, interactions with bones, perhaps in food, and it just always seems as if bones are so solid, and yet in reality, bones are constantly breaking down and building up. It's a very dynamic process. Could you just give us a quick overview on bone physiology?
Absolutely, and I think you've highlighted something I always try to stress when I talk to groups of people is that bones are not these inanimate objects. I mean, we're not these walking kind of lumbering rocks, moving down the street. In fact, we have this very important scaffold underneath our skin that enables us to walk and roll and twist and bend. And without a very strong scaffold, we're kind of in trouble. So you're right, bones are dynamic. Our bones are always building up and they're always breaking down. And it's that process of kind of building up and breaking down that allows us to be flexible, right? didn't, have remodeling of our bones, we'd be very stiff and brittle. But it's that balance, that key balance of how our bones build up and how they break down, that really dictates how strong our bones can be. Clearly, you would prefer a lot more building up than breaking down. And at different parts in our life cycle, or different times in our life cycle, we have different balances in that building up and breaking down. If you really the nitty-gritty of the pathophysiology, I think it's important to understand, because there are two very different types of cells that treatments for bone disease sometimes impact. We really boils down to these cells, one of which is called the osteoclast. It's kind of like a little Pac-Man cell that's responsible for breaking down our bone if it's an area of injury or a little microfracture. So that osteoclast will come in and kind of carve out a pit of bone so that the osteoblast, B as in build, can come in and fill in new bone, again, to rejuvenate that area and to keep your bones flexible.
And I'm assuming that as we get older, there are more osteoclasts, or they're moving faster than the osteoblasts building our bones back. Am I wrong?
No, I think that that's a wonderful way to think about it. The life cycle is complicated. When I meet patients for the first time, and again, I'm in a metabolic bone clinic, so I see patients who generally come already with a diagnosis of osteoporosis or low bone density. And when we're sitting there talking to one another, we say, gosh, why aren't your bones perfect? And believe it or not, what we do is we go all the way back to childhood, because changes happen throughout the life cycle to bones. We build or gain bone. We're building more bone than we're breaking down until about the third decade of life. So those osteoblasts are overtaking the osteoclasts to give us nice, strong skeletons. So you might imagine how early childhood insults could impact the bones. In midlife, we have kind of a steady state where the blasts and the clasts are kind of remodeling at a usual rate, generally in balance with one another. At around the time of menopause that women go through, there's a steep decline in bone density, which is driven primarily by those osteoclasts, those Pac-Man cells that break down bone at a much more rapid rate than the osteoblasts are able to keep up with. And men have an inflection point later on in life. They don't go through a menopause per se, but about the time, about 70 years of age or so, again, that imbalance starts to shift, which favors the osteoclast or bone breakdown, where again, it's kind of like a tortoise and the hare story. The tortoise is no longer keeping up with the hare, and the bones will break down.
Dr. Mosley, I'm curious as to how things have changed, because I suspect that our ancestors, and when I say our ancestors, I'm not talking about Neanderthals, I'm talking more about our grandparents and our great-grandparents. They were probably spending a lot more time outdoors, farmers and just workers, and both men and women were just physically more active than we are today. Today, I think we spend a lot of time sitting, and I'm curious as to how our lifestyles have affected bone health over the last, let us say, 50 to 100 years.
Now, I think that is a fair assessment. We know that activity, movement is critical for bone health. In fact, when we talk about the tenets of therapy for osteoporosis and low bone density, one of the things we always have to discuss in clinics, how can we get you more active? What kinds of exercises should you be doing? Because movement really stimulates those bones to kind of rebuild, grow, remodel. And so absolutely, back in the days when we were out and about, in the farms, or, pushing things, down the street, I think we did have a lot more activity related to our bones. I will also counter, though, we didn't live as long back in the day. And so that graph that I just kind of talked about, with this aging process kind of inevitably causing slow and steady bone loss as we get older, a lot of the implications for weakened bone really don't occur until that later stage in life, where women are postmenopausal or men are older. And so did we really see the full effects of osteoporosis and bone loss, in prior generations, when perhaps they didn't live to be the older ages where the fractures started to manifest, or people passed earlier from other conditions that we didn't have treatments for.
Dr. Mosley, I want to just revisit something you said a few minutes ago, and really bring it back up, because I think a lot of people think of osteoporosis as a women's problem. And you mentioned men get osteoporosis too. Tell us a bit more about that.
Terry, thank you for bringing that up. It is a very important point, and oftentimes, my practice is a lot of women in my practice, and oftentimes women will bring their significant others or their spouses, and they listen to my spiel, and they kind of turn to their spouse or significant other, and they say, "Well, gosh, maybe that means we need to screen you as well," and it's true. So men do get osteoporosis. It is a misconception that this is a women's disease. Statistically speaking, about 10 million Americans in the United States have osteoporosis greater than the age of 50, about 8 million of those individuals being women, 2 million being men, although even that statistic I counter. One big point is that we really underdiagnose osteoporosis. We don't, name it when we see it. And secondly, it relies upon screening for osteoporosis. And as we've just said, men really, we don't see this as a man's disease. So are we screening men to even be able to make the diagnosis in that portion of the population? So absolutely, bones thin at different times in our lives, but there are still other factors, other disease states, other medications that can threaten a man's skeleton just as easily as it can a woman's.
Well, you mentioned medications, and of course, a lot of men who are diagnosed with prostate cancer are given hormone-suppressing drugs, what we call anti-androgens. And I suspect that has a profound impact on bone strength, and not just in men, in women too, because testosterone, people think, oh, that's a man's hormone, but it's responsible for bone strength in both men and women.
Right. No, absolutely. So one of the biggest offenders, and the term is iatrogenic, meaning sadly, we as doctors do this to patients, deliberately, because oftentimes we're treating another disease state. We have no choice, but we do give patients oftentimes medications that have side effects that directly hurt the bone. One of those medications, in fact, is androgen deprivation therapy. So in prostate cancer, with a goal to get testosterone levels to zero, we give them these hormone blockers, and it's kind of like a menopause for men that they go through when we have that low testosterone. We know testosterone is converted into estrogen, so that causes low estrogen in men, which can hurt the bones. Women, there's a corollary with breast cancer. So our breast cancer survivors, we treat with drugs such as aromatase inhibitors, where again, we render estrogen levels to zero. And we see oftentimes a significant amount of bone loss associated with those medications as well. Probably the worst drug that we use, but oftentimes very, very necessary for patients with chronic inflammation or autoimmune disease, would be things like steroids. So steroids I always refer to as somewhat dirty drugs. If you need them, you need them, just like anti-cancer therapies. But those medications as well can really thin bones through a number of different mechanisms.
So the anti-estrogens for breast cancer, the anti-androgens for prostate cancer, and the corticosteroids that are used for so many different conditions, including autoimmune disease and asthma and COPD, all of those medications can have a profound effect. Should everybody who's taking one of those medications get a bone scan?
In my humble opinion, absolutely, and I think most guidelines would agree. It depends on timing. So the low-hanging fruit, the easy answer would be obviously treat it before it becomes a problem. Steroids, prednisone or an equivalent of 5 milligrams or more for 3 months or more continuously. Bone loss, screening bone mineral density test shows, and then follow the patient more closely. We're not as worried about the inhaled steroids. We're not as worried about steroid injections, the most problems.
You're listening to Dr. Kendall, Medical Director of Bone and Osteoporosis Center.
After the break, we'll learn the difference between osteopenia and osteoporosis.
If you break a bone, does that mean you have osteoporosis?
What are the options for treating osteoporosis?
Exercise might be helpful. Which ones are best?
Should you be wearing a weighted vest?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
Dr. India Woods here. As a veterinarian, I demand a lot of my scrubs on the job. That's why I show up in FIGS. FIGS are made for the sometimes crazy situations I find myself in. It doesn't matter if I have to squat, sit, bend, or even chase after one of my patients. FIGS moves with me and keeps me comfortable in the highest pressure situations. FIGS gives me one less thing to worry about. Get 15% off your first order by visiting wearfigs.com and use code FIGSRX at checkout. That's wearfigs.com, code FIGSRX.
You're a podcast listener, and this is a podcast ad.
Heard only in
More at getsonu.com. That's getsonu.com.
Today we are talking about bones. How would you know if your bones are strong or vulnerable to breakage?
What options are available to maintain bone health? Are some exercises better than others?
We're talking with Dr. Kendall Mosley, Associate Professor of Clinical Medicine in the Division of Diabetes, Endocrinology, and Metabolism at Johns Hopkins University School of Medicine. Dr. Mosley is Clinical Director of the Division of Diabetes, Endocrinology, and Metabolism at Johns Hopkins. She's also Medical Director of the Johns Hopkins Metabolic, Bone, and Osteoporosis Center.
Dr. Mosley, I think there are a lot of kind of long, complicated words that we need to deal with in this interview that people may have heard or maybe not have heard, but are not completely certain. What does it mean? So let's start with the difference between osteopenia and osteoporosis.
Right. I think that's a great question. There's a lot of big words in the bone field, and those would be the big ones that patients bring to the office. So we have to think about bone density and bone health and bone strength along a spectrum. So, spectrums are uncomfortable for a lot of people. We like to have our bins, our diagnoses. And so in the bone world, we divide things into normal. We say osteopenia, although we are getting away from that term. We more so use low bone density, and then frank osteoporosis. And the World Health Organization would define those three terms based on a T-score. And what is a T-score? So to make a diagnosis, to screen for osteoporosis, we use a very specialized scan called a DEXA scan. It's a dual energy X-ray absorptiometry scan. You can see why we call it DEXA. And it's basically a fancy X-ray. And it's a 2D interpretation of bone quantity, usually looking at the spine, looking at the hip, and it's two different locations in the hip. It's the total hip and the femoral neck. And sometimes we even look at a forearm in certain circumstances and disease states. And it's that fancy X-ray, again, that we use to follow osteoporosis, but more importantly, to diagnose it in those in whom we're worried that they have thinner bones. That T-score is really just a standard deviation. And the standard deviation is that individual's bone compared to that of a 30-year-old, which seems very unfair. But as I said earlier in the segment, we really gain bone until about the age of 30. So we're kind of comparing that patient to what their ideal should have been back in the day. A T-score, anything between 0 and -1 is considered normal, so normal bone density. Anything between -1 and -2.5 or 2.4, is considered low bone density or osteopenia. And anything less than or equal to a -2.5, again, -2.5 standard deviations from normal is considered osteoporosis. And that's what spits out on the reports, and that's oftentimes what patients bring to the clinic. Although it's very, very important to insert a big caveat here. People with low bone density or osteopenia can still fracture. In fact, the majority of fractures, which is the take-home message, we're trying to prevent broken bones, the majority of people who fracture actually are in the osteopenia or low bone density range, as compared to the osteoporosis range bone density. So if someone comes to clinic and maybe that DEXA scan says the T-score is a -1.5 or it's a -1.8, which technically again is osteopenia or low bone density, if that same patient has also had a fracture, a fragility fracture, that patient has osteoporosis. So it doesn't matter to me what this screening scan shows. If that bone has broken in a fragility manner, and gosh, I get that question all the time too, so I'm going to beat you to it. What is a fragility fracture? This is a fracture of the spine, hip, pelvis, wrist, upper arm, from standing height or less. So slipping outside on an icy street and bracing your fall with your wrist, if you break that wrist, that is a fragility fracture. Stepping out of the bathtub and maybe the floor is a little bit slippery and you come down hard on your hip and you have a hip fracture, that is osteoporosis. Falling out of a 2-story building or a motor vehicle accident and you break your pelvis, that's just lucky, walked away with just one broken bone. So again, fragility fractures, no matter what that bone density test is showing, whatever that score says, if you have a fragility fracture, you have a diagnosis of osteoporosis that should be treated. It's akin to having a heart attack, right? I don't need a cath if you've had a heart attack to tell me you have cardiovascular disease, and we have to take that seriously.
I've got a question for you, because our grandson, who's 7, was running the other day at camp, and he tripped and he fell and he broke his arm. That happens a lot to kids. You know, they fall off the jungle gym, or they fall off their bicycle and they land and out goes their arm and boom, they've broken it. Now, they don't have osteoporosis. Why would a woman who falls in a similar situation, maybe while riding a bicycle, why would she be automatically defined as osteoporotic?
Well, a woman who falls off a bicycle, that's considered traumatic, right? So, maybe it's less than standing height because she's sitting down on a bicycle, but she's fallen off of a, moving object, going presumably at a fairly rapid speed, and you get entangled in the wheels, etc. So I would probably talk through the logistics of that particular fall, and I would probably walk away saying that was more traumatic than atraumatic. Getting back to kiddos, they're a different bird. So again, falling off of a jungle gym, that's from a height higher than standing height. Kiddos also have just very different bones. So their bones are kind of built to be a little bit more flexible. They're a little bit more rubbery. They remodel at a faster rate. And so they do oftentimes get these fractures, tripping, falling, bonking their heads. We had that a couple of weeks ago in our household. We know those fractures heal very rapidly. Where we start to worry in kiddos, and this is probably beyond even the scope of our discussion today, is when there are multiple fractures, low trauma fractures, situations in which it doesn't make sense that arm or that leg breaks. And then there's a whole host of genetic conditions that oftentimes we will screen for to make sure that in fact that child doesn't have a metabolic
Well, I think it's important for parents to realize that a situation like that requires extra attention, but we're not going to follow through on that any further. What I'd like to do is go back to your idea that a fracture might institute treatment. And what I mostly hear from people my age, women my age, is that they have been told by their doctor that they have to take a drug because of the osteoporosis. And a lot of them don't want to take a drug.
Or the osteopenia in some cases.
Or the osteopenia. And the most popular drugs are the bisphosphonates like alendronate, which used to be called Fosamax. So what options are there for treating osteoporosis? Is bisphosphonates where you start, or are there other things people can do?
No, when I talk to patients, I break down into your to-do list going to look like, and that can be things like calcium, vitamin D, exercise, protein, other healthy lifestyle interventions, and we can get into that absolutely. And then there's things that maybe I need to do, when the prescription pad may need to come out. When we think about osteoporosis and how we treat osteoporosis, again, we love our bins in medicine. It helps to organize and kind of talk to people about how we're thinking about their disease state. And osteoporosis is no different. We think about it on a spectrum. So is the osteoporosis mild? In a mild case of osteoporosis, maybe just low bone density, no prior fractures. We sometimes use a tool, Frax calculator, guidelines. If we're seeing signals that things are generally fairly positive, we might just recommend lifestyle interventions, calcium, vitamin D, some good exercise, protein, etc. As we move further down into the different bins, we get into different categories. So moderate osteoporosis or low bone density, where again, the DEXA scan is giving us data we don't like to see, the numbers decreasing, happening at home, the Frax calculations are more elevated. That might be a category in which, in addition to lifestyle intervention, we might recommend medical therapy, usually something more mild. If we think about it as a swimming pool, we start calcium, vitamin D, exercise. That might be a place at which we do start to recommend more intense pharmacotherapy. That might be a place at which we do start to recommend more intense pharmacotherapy. That would still be an oral pill, maybe an infusion, maybe an are about their If you're in a Fisher category, we might want to start with a bone building drug. But if you tell me all you're willing to do is an oral pill once a week, I'd rather not let perfect be the enemy of good, and we might start with something milder, despite what I think.
Dr. Mosley, you've mentioned exercise a couple of times, and we've gotten all kinds of recommendations.
In a wheelchair and a walker, but it's important that they move their bodies. Walking counts in terms